Right, let's go ahead and get started. Welcome, everyone. This is the April session for the California HPV Vaccination Roundtables, Learning HPV Vaccination Learning Collaborative, and we're very excited to have everyone with us today. All right, so just some housekeeping for this session. All of you have been muted to ask a question when we get to our Q&A session. You can just take yourself off of mute. You can also drop questions in the chat. We will be monitoring the chat if you don't want to come off mute. We are also recording this webinar and it will be posted on the California HPV Vaccination Roundtable website. And as always, please help us with evaluation of this effort, and we'd like to hear from you at the end. So we will be dropping an evaluation link in the chat. All right, so today our icebreaker is if you could live anywhere in the world for 1 year, which location would you choose? So we want to hear from everyone in terms of who is on the call, your name, where you work, your position. And I didn't introduce myself. I'm your host today. I am Shantae Davis Patterson. I'm the program director for California's Comprehensive Cancer Control Program. We administer the State Cancer Coalition, the California Dialogue on Cancer, or CDOC. We also have co-founded and helped co-lead the California HPV Vaccination Roundtable. So go ahead and drop all of your um, info in the chat there. This learning opportunity is being brought to you by the Engaging Health Systems and Providers work group of the California HPV Vaccination Roundtable. So, what is the California HPV Roundtable? We are a coalition of diverse stakeholders who have a goal that by 2035, at least 80% of 13-year-olds in California will be up to date on the HPV vaccination series. And you can learn more about the roundtable if you go to our website at cahpvroundtable.org. And the picture that you see there in front of you is the latest or the last annual meeting that we had in December in Los Angeles. All right, so our agenda today, we're going to do some HPV vaccination roundtable updates. And then we will have our feature presentation from Dr. Jennifer Tsui, titled Advancing HPV Vaccination in Safety Net Settings, a collaborative approach to implementing and sustaining evidence-based strategies. Then we'll proceed with our question and answer session after the presentation, and we will close. All right, so I'm gonna just go through some updates really quickly. And if I have some colleagues on who want to jump in as well, they can do that as well. So first, we do have, and actually, Joyce, can you go to the next slide? The next slide after that. I want to start with the description of these. Oh, I didn't have those. Okay, if you can go back to the first one. Coming up in May, we have a webinar series that we have collaborated with the CDPH immunization branch, as well as a couple of other partners. Our on the webinar in May, we're calling it Learn and Earn because you can have one CME credit for this. We will have Dr. Irene Landau, who is a pediatrician and a vaccine advocate, and also a member of our Engaging Health Systems and Providers work group of the roundtable. She's going to be presenting the evidence-based announcement approach training. This is the training that we promote widely here, and Dr. Landau is our trainer that's able to provide this training. But this is the second webinar in our series of Boost HPV Vaccination Quality Improvement webinar series for California clinicians and staff. It is co-hosted by AAP, AAAP, American Academy of Physicians, Orange County, and the Roundtable, of course. And again, we are working with the American Cancer Society as well as the California Immunization Coalition on this as well. So if you can go to the next slide there. This is our flyer that we have, and we will try to drop the information in the chat for this. And we'll also be sending all of this around for the series because there's another webinar that's coming up in June as well. Also, register now for the California Immunization Coalition 2026 Annual Summit. It will be June 3rd to June 4th in Sacramento. We'll get all these links for everyone. Also, save the date for the California HPV Vaccination Roundtable annual meeting. So we will be in Sacramento this year for our annual meeting, and it's going to be Thursday, December 3rd. Oh, there's the Keck registration information. All right, so I'll go through our work group updates. Our announcement approach training that I just mentioned, we are still providing this training. It presents strategies for recommending the HPV vaccine to promote vaccine acceptance and save clinical time. It's designed for providers interacting with parents. You can learn the latest on HPV vaccine research and guidelines, as well as brief evidence-based communication. It's only 1 hour. We do it online. Contact us to schedule a training. We would love to do one. It is free. All right, so this is the webinar series. I got kind of turned around when I saw the other flyer first, but it is a whole series, a collaboration between the Roundtable CDPH Immunization Branch, as I mentioned, the California Immunization Coalition, as well as the Orange County, California division of AAP. It is a 3-part interactive webinar series focused on practical evidence-based strategies to increase HPV vaccination coverage in clinical settings. There's individualized support from the Vaccines for Children program. And there's also QI consultants will be offered to participating clinics. And then I've already mentioned who it's hosted by, and we do have one CME credit available per webinar. So this is the schedule of all 3 of the webinars. April 8th has passed, obviously. It was building trust and tailored messaging. We're working on getting that recording up for those who have missed that particular webinar. The next one is announcement approach for vaccine confidence that I mentioned and went over thoroughly. And then the last one is using immunization data effectively, which is going to be scheduled for June 10th. And for that webinar, participants can expect to understand how to use immunization registry and EHR data to monitor coverage, identify gaps, and improve workflows. So amazing series that we've put together. Once you register for one, it'll prompt you to register for all of them. So we'll drop that information in the chat as well. And then we have a celebrating 20 years of the HPV vaccine event. This is an event that's going to be on May 20th. It's a virtual celebration, and it's of the Western Regional Summit on Prevention and Progress. So this summit will be featuring expert speakers, Q&A, and networking with regional leaders to reflect on 2 decades of HPV prevention progress and explore future strategies. Participating states include Alaska, Arizona, California, Colorado, Hawaii, Idaho, Montana, Nevada, New Mexico, Oregon, Utah, Washington, and Wyoming. It's all of us on the West Coast side that's getting together for this celebration for 20 years of the HPV vaccine. We will have more information and details on registration. So just watch for that. We'll send all of this information out on this list if you have registered for the our Learning Collaborative series. All right. And just a quick recap on Adolescent Immunization Action Week. Adolescent Immunization Action Week was a national campaign that took place last week, April 6th through the 10th. And we want to keep the momentum going by continuing to highlight the importance of vaccines for preteens and teens and urging healthcare providers and parents to fully vaccinate adolescents, excuse me. And then the Unity Consortium and the Clinton Foundation co-hosted a webinar last week on April 8th titled Who Influences Young People's Health Choices, which highlighted how trusted messengers shape vaccine decisions. The event featured Dr. Margot Savoy, Dr. Jess Steyer, and Dr. Liz Marnick. So here's what's still available and how you can continue supporting this work. The AIAW toolkit is available online, and we'll drop those links in the chat. And then also just keep the conversation going. Continue boosting visibility by sharing social posts and resources from the toolkit. So even though the AIAW has passed, we still have those resources in the toolkit available. Um, and Raquel, did you want to come on for this slide?
Sure. Sorry. Oh, I wasn't expecting it. Hi,
Oh, it's
everybody.
okay.
Sure. Not much here. Just a reminder that the California HPV Vaccination Roundtable is online on social media. We have the wonderful Kim Wuttecho. I'm sorry, Kim. I always pronounce it wrong. That manages our Instagram and Facebook page. And so please, you have the QR codes here. I can put them in the chat in a second too if you want to go on your browser. So please follow us and engage with our content there. I'm not sure if you just mentioned this, but for last week, Adolescent Immunization Action Week, we had some great content featuring one of our new members, Lucas, sharing his story. I think there's an animation that might have some other deeds on here. I'm gonna click. Yeah, there you go. So yeah, just a couple calls to action to you. This is where you can also find on our website that first QR code, the social media toolkit that was put together for California HPV Vaccine Week. But those assets are really not specific to that week. You can see some of the examples on the slide.
Awesome. Thank you, Raquel. So Bridget or Raquel, or I can present this slide.
Yeah, I'm happy to keep doing it. This is basically just an FYI. This is an ongoing opportunity from the American Cancer Society. This is the 2026 one we've done in the last couple of years. It's a rural learning community. It used to be focused on HP vaccination only, and now they've actually added some content on cancer screening as well. So the next one, oh gosh, I think it's I don't know. I'm not gonna. I'm like, what did it just happen? Is it today? Second Wednesday of every month, and that's ongoing till November.
Thank
And I think
you,
that's
Raquel.
it. Thank you.
All right. So for our feature presenter, and I'm happy to introduce our presenter here. We normally have a bio document that we drop in the chat, but we are having some difficulties doing that. So I'd love to introduce Dr. Jennifer Tsui. She is a professor in the Department of Population and Public Health Sciences at the Keck School of Medicine and at USC and Cancer Control Program co-leader and director of Cancer Care Delivery Research and Implementation Science at USC Norris Comprehensive Cancer Center. She is also a faculty member of the USC GERT Family Center for Health System Science and Innovation. Dr. Tsui is a health systems I'm sorry, Dr. Sway is a health services researcher and implementation scientist. What they focus on reducing inequities in cancer care access, quality, and outcomes through implementation of evidence-based strategies and health system community, and policy level interventions, particularly among marginalized populations served in safety net healthcare settings. Dr. Sway currently leads a National Cancer Institute funded study that examines implementation of evidence-based strategies for HPV vaccination in safety net settings. Dr. Sway is also a member of the HPV Vaccination Roundtable Steering Committee and a couple of our work groups, and is always ready to jump in and help us and with her expertise on all the things. So we really appreciate her coming to present. And without further ado, I'm going to turn it over to Dr. Sway.
Thanks, Shantae. I love being part of this and this group and all the steering committee members and all the organizations that are part of this. So it is really my pleasure to be part of this group. And thanks for inviting me to present some of our work today on this study. Let me just double check. Am I screen sharing the right thing, which is always task number one?
Yes.
The right
You see your speaker view. No.
Oh, see, it's always there trying to trick us. How about now?
There we go. Yep. Looks great.
Now we're good? Okay. And I will just say I'm continually amazed by how many things are covered all the time during these learning collaboratives and all the many events that are happening across our state, but also across the region. So I'm ready to celebrate 20 years of the HPV vaccine. So with that, I'll start today with just an opening on the study that I'll be talking about. I hope throughout the next 20 minutes or so, I can highlight the many, many partners, clinic collaborations, and research team members that have been part of this study over the past 5 to 6 years. And if I forget and you're in the Zoom room, please chime in the chat. This was definitely a team effort, and it takes a village to do this kind of work, as you all know. So, let's get started with that. So today I'll be presenting on one of our NCI funded studies. It's a multi-year study to examine how we can implement evidence-based strategies to improve adolescent HPV vaccination in safety net settings. So federally qualified health centers, other community clinics, etc. So first, I always like to start with this slide. Just recognizing that we know in the field of cancer control and cancer prevention that implementation or adoption of evidence-based practices in cancer control has not been as fast moving as we'd like it to be, right? So if you take a look at mammography, colorectal cancer screening, and HPV vaccination, for example, it's taken a while to go from the original science that came out to show that these tools for cancer prevention, cancer screening, early detection work to the time where we feel like we've reached population levels of uptake. And Shantae and the team just mentioned we're about to celebrate this year our 20th anniversary of the HPV vaccination. And we know that the vaccine in many areas and in many of the communities we work with are still not at that optimal level of uptake that we'd like to see, right? But what we do know is that the vaccine is highly effective. We know that it can prevent multiple cancer types, or it can prevent HPV types that are associated with multiple cancer sites. And what we know around the world, in regions where uptake or implementation of the vaccine has been high, that we are starting to see the benefits at the population level. Scotland reported 0 cervical cancer cases a couple of years ago. Australia, in recent months, have said that they're set to be the first country ready to eliminate cervical cancer. We've seen regions with 0 new cases of invasive cervical cancer. And so we do see sort of 2 decades later what we can achieve when we have high population level uptake of the vaccine. But what we do know and what many of us encounter day to day in our work is that optimal population vaccination rates for HPV really requires multi-level strategies, right? Strategies to support awareness, to help providers recommend the vaccine, to address hesitancy. And this is coupled by two things, right? The first is that over the past 2 decades, we've seen changing guidelines, a focus on younger age groups starting at age 9. We've seen recent data come out and guidance in other regions of the world moving to one dose. I'm still unclear what we're doing here with recent ACIP changes, if we are a one dose country or not currently. And lots of multi-level challenges around hesitancy, misinformation, lack of awareness, and physician and clinic team strategies to get shots in arms, right? So we know multiple challenges that exist in how we recommend and administer the vaccine in many of the communities we work with. In LA specifically, these are actually hot off the press by our team. Morgan Gill, who's on the call today, looked at these rates very closely for LA County from the most recent release of the LA County Health Survey from 2023. And we're still seeing that we're hovering right there around 55%, right, in adolescent HPV vaccination uptake. There's lots we can talk about with this most recent survey, and I hope some of you on the call today maybe have more insider information about the data. But one thing we did learn is that we did see an increase adolescents in adolescent boys in uptake. So we've seen some increase, we've seen lots of improvement, much to the credit of what all of you are doing out there in the field. But there's definitely room for improvement still. Our team had looked a few years ago at this relationship between medical mistrust and parental HPV vaccine hesitancy and found this relationship across multiple language groups. The more medical mistrust a parent has, the more likely they are to also be hesitant towards the HPV vaccination. And so therefore, we need lots of strategies to reach multiple groups, right? Including just basic information and awareness about the vaccine. This is one of the results of that medical mistrust study, where our team, in collaboration with our USC Norris Community Outreach and Engagement Program, have done extensive work in the community on raising awareness around HPV vaccination. So that leads me to the focus of the study that I'll be talking about today. And the sort of background around that is over the last 2 decades, we've seen a lot of evidence of strategies that can work for helping to improve adolescent HPV vaccine uptake in clinic settings, right? So the announcement approach, which I'll talk about in a bit as well, but that Shantae had mentioned earlier in the call today with Dr. Irene Landau sort of being that key expert deliverer of the program that, has been cited across the country as an effective strategy. Reminder calls, standing orders, lots of in-clinic ways to improve HPV vaccination. The research question here for our team and for this multi-year study I'll talk about today is really on understanding what are the processes we need to identify and adapt strategies to fit clinic settings? What do we need to do to get these strategies to actually be adopted, implemented, sustained, and then how do we scale these things up, right? And a lot of this has to do with the need for adaptation, right? Understanding those outer setting community policy level factors in our local region and state, and then the inner setting factors of clinics related to the clinic team culture, infrastructure capacity, target patient population, and how they engage with them inside the clinic. And then these pieces about the strategies, right? How do we get those strategies to work in these inner settings? So a lot of what we've done with the project I'll describe today is around understanding adaptation, making the content and the content and the logistics of the strategies fit local FQHCs. So this study was a 6-year study, originally proposed as a 4-year study to NCI as an R01, really to focus on this 4-year implementation phase to understand factors associated with implementing evidence-based strategies, and then understanding sort of the impact and the effect of implementing those evidence-based strategies. And then what we did was in the 2 years following the main grant, I'm trying to see. There we go. In the 2 years following the main grant, sort of understanding what are the factors that impact sustainability and scaling of these evidence-based strategies. This is our research team. It's evolved, as you can imagine, over the last 5 to 6 years, as have our partners, right? And this is where I really have to emphasize why I want to talk about partnerships as we discuss sort of what we learned in this project today, because this is a partnership study. It's a partnership research project that involves sort of state level collaborators like Shantae and Dr. Landau in the California HPV Roundtable, but also the American Cancer Society, other components of our cancer center, as well as the clinics we've worked with. So I want to start here in terms of framing our research study. This is an implementation science study, and if you're new to implementation science, this is a great sort of handbook that can give you a crash course. These are sort of the 4 steps, right, in implementation science that we've largely covered throughout the last 5 to 6 years of this study. Assessing what evidence-based interventions are needed, engaging in stakeholder partnerships, preparing, adapting these interventions, implementing them, and then evaluating the impact of these interventions and how they can then be sustained or scaled up. So why do we focus on FQHCs? Well, we know that adolescent HPV vaccination rates remain low in medically underserved communities, and FQHCs are a primary source of patient care and primary care for over 30 million Americans. Few evidence-based strategies for HPV vaccination have really targeted clinic staff, though we know they're a big part of care delivery in FQHCs. And lastly, there's less known in the field in implementation science of how we work with co-designing interventions, not just with clinic leadership, but clinic staff, clinic physicians in clinics, and learning all the ways that a clinic functions and how we can best integrate evidence-based strategies. So in the first part, way back in 2020 of this study, we interviewed so many of you, actually, who I think are on the call today. I won't name any names. That's part of our IRB to not disclose you, but we first started out just trying to understand, well, what are the experiences with adopting and implementing strategies for HPV vaccination currently? At that point, it was 2020, 2021. And then we went and we asked the same stakeholders, as well as some other ones, to prioritize and identify which strategies would be most feasible for FQHC settings. We came up with this concept mapping finding where we found that provider recommendation, looking at nurse to clinic staff workflow, expanding vaccine access, and reducing missed opportunities were identified as most important and most feasible. And from there, we worked with one large FQHC here in LA to figure out how to translate those stakeholder findings and prioritizations into strategies that we can implement in the actual clinic. And that really led to these 3 strategies that were prioritized for our work with UltiMed here in Southern California. So these strategies are audit and feedback, the provider communication training, the announcement approach, which I'll go into a little bit more, and then staff education and workflow assessment. So the study itself took place over a 12-month evaluation period where we implemented all 3 strategies in 3 demonstration sites within the UltiMed FQHC system. We had a baseline assessment period. We went in and delivered the 3 strategies. We assessed through site visits and interviews, how things were going throughout that implementation period. And then we did a post-implementation assessment. Data collection were guided by implementation frameworks, implementation outcome measures through the RE-AIM framework. The first strategy was really audit and feedback. So we did this with the 3 clinics. We had monthly meetings where we shared back the data we were finding at baseline to help inform the adaptation of the strategies we were going to implement. We co-designed and talked about how those strategies or interventions should be delivered to clinic staff and to providers. And we continuously tried to assess other things that were going on in the system, like standing orders and nursing staff education that were happening simultaneously in the real world so that our interventions could be aligned with what was happening in the system itself. So aside from audit and feedback, one of the second strategy that we implemented was provider communication training. This was back in 2022, 2023. We delivered this training twice, once to the attending physicians at all 3 clinic sites, and then once to the residents at the clinic sites. It was led by Dr. Irene Landau and Shantae Davis. And what we found was that we had several adaptations, right? At that point, we were moving down to age 9. We needed to provide local level and clinic rates to make the training effective or relevant. We talked about the impact of COVID and what it meant to have COVID vaccination as part of this group of vaccinations that this age group was getting. We also focused on what they needed in the clinic in terms of delivery mode of the training, having a virtual session, having separate sessions for the residents, going back to the UNC colleagues, the University of North Carolina colleagues who developed this training to talk about these adaptations as well. And one of the major outcomes we saw was that after the training, we had a higher proportion of physicians endorsing starting at age 9 for the vaccine. The third strategy we used was to implement clinic staff education and workflow training. The education training was led by our program manager at the USC Norris Community Outreach and Engagement Program, Dr. Carolina Aristisabal, where we also focused on starting at age 9, educating clinic staff about parent concerns, addressing myths and misconceptions around the HPV vaccination, and then identifying messaging that we needed, that they were hearing from their clinic patients and the parents of patients, what the hesitancy points were. What we found was that after the clinic staff trainings, there was an increased reporting of clinic staff confidence in addressing parental vaccine hesitancy. One of the key outcomes that we developed from this process in co-designing our clinic staff training with the Ultimed team members and leadership is that they wanted a little bit of like a back pocket cheat sheet of what they can say if parents bring up concerns around the vaccine. We provided these in both English and Spanish. They're directly from the data that we gathered at baseline and throughout our site visits, and so they were relevant to the patient population that they were seeing. The last thing we did with the clinic staff training was to identify workflow opportunities. We had some varying reports of whether standing orders were being used, how parents were being outreached to if their adolescent had missed a vaccine appointment. And so Dr. Samantha Garcia, who I think is on the call today as well on our team, really led the training on this component. And at this clinic staff training, we went over what the standard workflow was and discussed points of opportunity where there could be more vaccination impact. And so a lot of what we found, again, we found an increase in being confident by staff to address parental HPV vaccination concerns. A lot of it was knowing how to use the terminology, how to use the resources that we provided in the training so that they felt like they had the tools to talk about what parents were bringing up in the visits around HPV vaccination. So, what did we find at the end of that 12-month implementation period? We found that HPV vaccine initiation increased for adolescents at a greater rate in those three clinics compared to the other ultimate clinics where we had not implemented the three strategies. We did find that HPV vaccination rates increased overall across all Ultimate clinics in aggregate, especially for ages 9 to 12. And some of this was as we were working with Ultimate, they had also implemented other tools in their clinics to improve HPV vaccination simultaneously. I don't know if Stacy DiCario is on the line, but she's the director of vaccines at Ultimed and has been a great partner in talking about their own internal system strategies for looking at vaccination strategies overall. Another outcome that we really focused on was what was driving those changes in the intervention sites. And what we found was that much of the improvement in vaccination rates were driven by the 9 to 10-year-old age group. A lot of what we focused on in the training was starting at earlier ages. And so it was really looking at that increased rate in the intervention clinics in improvements in age 9 to 10 uptake. Sorry for making you dizzy there. So at the end of that piece of the research study, we really wanted to go further, right? A lot of what we know in research is it ends when the intervention ends. We evaluate it, we publish some papers, and we're done. In this study, we really wanted to understand, well, what happens afterwards, right? What happens after implementation? How can we sort of identify what could impact sustainability and sustainment of vaccination rates? What we know in the field of implementation science is that longer term outcomes are often not studied for a variety of reasons, right? And so we really need to learn more about how to keep these strategies going or how to keep them dynamically evolving with the external context of either new guidelines or changing concerns in communities. So we wanted to understand sort of those inner and outer context factors that might impact keeping these types of strategies, this knowledge and this confidence sustained. So this is what we did in the 12-month component. And this is what we did sort of 18 months after. We went back to those same clinics to try to understand factors that impacted sustainability. First, we found that even after leaving for 18 months, that the discussion at age 9 was sustained as reported by clinic team members. In fact, it had gone up slightly for age 9-year-olds, up to 88% of survey participants in those ultimate clinics reporting that they started age 9. And then confidence had remained, right? So 69% at the sustainability assessment reported that they still strongly agree that those trainees increased their confidence in addressing parental concerns. We used this scale called the Clinical Sustainability Assessment Tool to try to understand what other factors or what components impacted sustainability. And we found that there was sort of high endorsement that the trainings that we implemented 18 months ago were easy for them to use, could be integrated, were designed to be used consistently. And then most of the staff agreed that they were associated with improvements in patient outcomes. For the provider surveys, they equally agreed they were easy to use and could be implemented into established clinical workflow, practice, EHR, etc. But there was a lower dip in thinking about whether the provider trainings had a meaningful or clinically meaningful impact on patient outcomes. From a qualitative component perspective, we found that there was large interest in continuing the use of the three strategies across all clinic groups, providers, and staff, that there may be this interest in having annual trainings. There's an opportunity to integrate that staff worksheet, for example, the messaging worksheet, into the Ultimate SharePoint and into the onboarding process for new hires. And also this discussion around sort of should we continue with live trainings, or should we use recorded trainings from the original delivery format? So the last piece on sustainability that I'll focus on is really just this part around what did we find? Were rates sustained? So 18 months later, what we found for that 9 to 10 age group was that rates were largely still sustained in the intervention clinics, right? Of all the adolescents that came in that sustainability period, we were seeing the same rate of initiation uptake. So is there more after sustainability? What's next after sustainability? Well, one area we wanted to tackle that we thought was also missing in the literature for implementation science is understanding what does it take to then expand and adapt from this large FQHC system to other FQHCs or other settings, right? So scaling up or scaling out. So we went from Ultimate to working over the past year and a half with two other FQHCs. One is Chinatown Service Center and one is Riverside San Bernardino. In addition to doing surveys and follow-ups with these two clinics and delivering both the AAT, thank you, Shantae and Irene, and the clinic staff trainings. We also, I think 2 years ago, sent them to the HPV vaccination roundtable meeting. So there were representatives from both of these scale out FQHCs who attended that December meeting in Sacramento. We are still analyzing that data, but I think what has been interesting or what's come out of what we've learned so far, many of you know, if you've seen one FQHC, you've seen one FQHC, right? There's different number of sites, different populations that all of these FQHCs target, but there were some overlapping sort of knowledge and awareness needs, and there were some agreement on the benefit of the trainings and the need to implement these evidence-based strategies. I'll say what's different, maybe, or an emerging difference is the baseline of where clinic staff have started in each of these three settings. So in some settings, the FQH staff have been very familiar with the HPV vaccination guidelines, while others have not. In some clinics, we've noticed that there's a higher reporting of parental vaccine hesitancy, whereas in another clinic, it's more about awareness. So there's some emerging differences that I won't go over today, but just to say that the strategies we've seen are beneficial to all the settings, and there have not been sort of major sort of mismatched alignment around the three strategies. I do want to go over a little bit about just differences that we've seen, though, right? And adaptations that are required, even if the HPV vaccination content in the strategies don't need to be changed too much. So Ultimate is a huge FQHC system. The sites that we were in were primarily serving Spanish-speaking patients. We had providers and staff who were 20 to 60% speaking other languages. There were a lot of providers. And so that's where we started. When we moved to scaling out, Chinatown Service Center had smaller sites. They had a smaller overall number of patients, and they had a different non-English speaking population. When we moved to Riverside San Bernardino, this is a Indian Health Service clinic targeting American Indian, Alaska Native patients. And we see again, while not very many non-English speaking patients, there were other cultural aspects and vaccine hesitancy aspects that were slightly different from the other two contexts. So the other aspect about scaling out that we had to focus on was how do we deliver trainings to these new sites? When do their clinic staff get together? Is it monthly in person at one location? Is it a super Thursday or Tuesday is what Riverside San Bernardino uses? And is that where they all remain at their own sites? And how can the clinic staff trainings be most effective when we're delivering via different logistics, etc. So those are all things to keep in mind as we do scaling of evidence-based strategies. So some key conclusions. Hopefully I'm good on time. First, it's that engaging with the partners is key, right? We want to make sure that the clinics are ready, are interested, have HPV vaccination on their sort of priority list, but also are acceptable and willing to sort of work together to see what's the best way to implement these evidence-based strategies. We are finding that of the three focus areas or three system provider and then clinic staff areas of focus, that the staff targeted trainings um, really have been very interesting. I wouldn't say the most interesting, but just very interesting and very new to what we've seen in other multi-level interventions. And I think that that really is a piece of working in FQHCs that's new. There's a lot of staff, diversified MA roles that we need to think about, front and back office staff who equally need to be trained if they're engaging in conversations with parents about scheduling the vaccine, information about the vaccine. Adapting trainings to meet the needs of those target communities that the FQHCs serve is vital. It's not a heavy lift as long as we have the right partners. And that was so key here that while we could have the HPV vaccine content be sort of from our American Cancer Society partners, our state roundtable partners, other sort of content sort of experts, it was really figuring out the right language and the right cultural components. Those really required community partners and clinic partners to help us adapt and engage. And then lastly, this area of sustainability and scaling, this is where we want to go, right? We never want to end one research study with one clinic system, write a paper, do a few presentations, and end it at that. It really is thinking about how do we leverage these resources so they're more accessible to other settings, other communities. So that's a lot of where our focus is now in the last year of the study. There are a lot of people to thank. It is a full village. It takes many years, and there's so much work that we've all sort of put together. And I'm hoping that from this, we have team members on our team that have started out as students and now have moved on or have started out as postdocs and now are assistant professors and launching their own careers. So it's really, I hope, a ripple effect of what we're learning here and happy to share the resources. We're just in that dissemination phase of sharing many of the resources. I'm going to end on this slide. This is another study that we have that's ongoing, and it's on the other end of the cancer continuum. So HPV vaccination, the more we can vaccinate, the fewer of these cases we'll see. This study, the ACHIEVE study, is focused on cervical cancer survivors. It's a study I co-lead with my good friend and colleague, Dr. Dana Llanos, based at Columbia University. We are enrolling cervical cancer survivors for both surveys and qualitative interviews. If you're interested or you know of a survivor, please scan the QR code. This is a study where we're trying to understand how we can develop multi-level strategies to impact structural and social barriers to optimal cervical cancer treatment and survivorship care. And with that, I promise that's it.
All right. Thank you so much, Dr. Tsui. We have gone a little over time, but that's okay. Everyone is still on. If there are any questions anyone wants to ask right now, since we're still on, please raise your hand or drop them in the chat. All right. Don't see anything in the chat here. Oh, Raquel.
Sorry, I couldn't find the hand to raise.
That's okay.
Thank you so much, Dr. Say. That was such a great presentation. I have a question about, actually, I have a partner on that I'm working with to do some clinic level trainings. I'm just wondering, you kind of alluded to it, but if you could say more about like the type of training and the format. Was it always the announcement approach training? Did you make any adjustments to it, like for cultural relevance? Did you ever do any format? I know you mentioned like a hybrid. But did you try any different types of trainings, like a self-paced module, or was it always done live? And also applicability for those that are more support staff, right? Like MAs, front office staff.
Yeah, so in this study, we just did AAT with the clinicians, the MDs and the MPs. We did in the Ultimate setting do both. It's always been hybrid, so we don't have to fly Dr. Landau down wherever she is. But we have been doing it sort of hybrid virtual where we'll have research staff in person. The clinic staff training has been both individual clinic sites in person, real time, real people. It has also been virtual hybrid where we have the trainers virtual, but the research staff in person, or yes, research staff in person. But that's something that we really want to examine, right? Is it equally as effective if it's self-paced and recorded? Can we scale up by making it that way, right? And so maybe things we can talk about in one of our work groups or at future roundtable meetings.
Thank you.
All right. Thank you so much. And thank you everyone for staying on. We would love for you to complete our evaluation form. It is dropped in the chat there. There it is. And Joyce, can you just give us the last slide on our next webinar is going to be Wednesday, July 15th. You can view past recordings on our website, as we always mention. And again, I just want to thank everyone for staying on, giving us your time this afternoon. And we look forward to seeing you in July. Thanks, everyone.